nostril. Tell me, what can you smell?
Orange.
Tell me what you can smell.
Vanilla.
Tell your face I'm touching. Feeling the strength of the jaw. Open your mouth slightly and don't let me close your jaw. Push your chin against my thumb and against my finger. Okay. Lift your eyebrows up and close your eyes tight. Don't let me open them. Puff your cheeks out, showing your teeth. Okay. And open your mouth for me. I'm just going to gently touch the back of your throat. Open your mouth again and just say ah. Stick your tongue out and say ah. Just watching the uvula rising and falling in the midline. Get you to stick your tongue out again. Ask you to turn your head against my hand. Same on the other side. And shrug your shoulders up and don't really push them down.
Our head, and so looking at it, it's round, it's firm, and it's normal cephalic. And when I do this, do you feel any tenderness? No. Awesome. So no tenderness. And I'm going to feel TMJ. Can you open your mouth and close it? So no clicking, so no TMJ. And then I'm going to feel the lymph nodes. And let me know if you feel any tenderness. Okay, and then I'll go post-auricular and preauricular. And then I'll do the submandibular, and then the submental, and then go down the clavicle chain. Any tenderness? No. Okay, good. So no tenderness, and just, okay. Good. Okay, good. So I can see that her pinna is in line with her eyes, and so, and then when I palpate the ear, pinna and the tragus, let me know if you feel any tenderness. Any tenderness? Mm-hmm. Since she's an adult, I would lift up and out, and then I would take the otoscope upside down and use my pinky to just balance and make sure it doesn't go in. And I'd look in, and I'd look at the tympanic membrane and make sure that it's a pearly gray and that it's reflective of the light. So they're both about a 2+, and they're equal bilateral. And then I'll look at her fingers. I'll do, since she has nail polish, I'll do the capillary refill on her fingertips. And so it's immediate, and then I'll do the trigger. And she has immediate recoil. So it's aortic, pneumonic, herbs, and then tricuspid, and then we'll put them. Okay. So there's no noted for any tenderness. Is it tender? Okay. What about this? Good. And then can you point your toes for me? Can you flex them? Good. And then I'll feel for the the posterior tibial, and it's about a 2+, and then the dorsalis pubis, and that's also about a 2+. And I'll go to the other one. It's 2+, and then dorsalis pubis. 2+. Good. So her pulses are equal bilateral. And then
leave it at all?
Begin the examination by identifying areas of the head: frontal, parietal, temporal, and occipital regions. Inspect the scalp for any lesions or abnormalities. Inspect the natural hairline and note any hair loss or any other abnormalities. Identify areas of the face, the forehead, orbits, zygomatic bones, maxilla, mandible, and note any facial lesions or deformities. Palpate the head and scalp for any lumps, tenderness, or lesions. Palpate superficially the temporal mandibular joint for the presence of any tenderness.
Does this hurt?
On the right side.
Open? Close?
Also, place the tip of your index finger in the ear canal and apply anterior pressure against the TMJ. Then ask the patient to open and close the jaw to elicit any reproducible pain.
And close? That looks tender.
It is.
Palpate the parotid glands and submandibular glands. Inspect for obvious swelling of lymph nodes in the neck and axilla. Palpate the lymph nodes with the pads of your fingers, the preauricular, postauricular, suboccipital, tonsillar, submandibular, submental, superficial and deep cervical, posterior cervical, supraclavicular, and axillary nodes. The inguinal nodes are also part of the lymphatic system and can be checked in the genitourinary exam. Inspect the trachea for midline position and note any tracheal deviation. Inspect for any masses or other lesions. Identify the anterior neck triangle, which includes the anterior neck midline, the jawline, and the anterior fingers over the thyroid gland, gently applying pressure on one side while the patient swallows saliva.
Swallow?
Note the size, presence of tenderness, and/or any nodules.
Swallow again.
Auscultate. Listen on both sides.
It looks like you have a problem with your temporomandibular joint. There's some irritation in it. We'll talk about that in just a moment.
Okay.
Get the starting measurement again. Looks like we are at 48 this time. And this time we're going to go back towards extension. And this measurement is second metacarpal and the second proximal phalanx. The axis in this measurement is going to be at the junction between the first metacarpal and the second metacarpal. So you need to find those bones, palpate them, get to the end of the joint, and then meet in the middle, and that's going to be the junction. So that's where you're going to put your axis. The stationary arm is going to be parallel with the second metacarpal, and the movable arm is going to be parallel with the first metacarpal. So we have to make a measurement of the starting position. Right now we are at 30 degrees, and from there I'm going to passively put her thumb in as much abduction as possible, Get the movable arm parallel with the first metacarpal. And we are at 55 degrees. So 55 minus 30 is 25 degrees of abduction. According to the Clarkson book, and I'm going to put her thumb into abduction and extension. I'm going to apply pressure against the distal first metacarpal, and I'm going to push towards flexion and adduction. Jenny, don't let me move you. Good. The next muscle is the abductor pollicis brevis. This muscle abducts at both the first CMC joint as well as the first MCP joint. I'm going to stabilize once again at the wrist, and I'm going to put the patient's thumb into abduction. I'm going to resist at the distal part of the first MCP and towards adduction. Jenny, don't let me move you. The wrist also in the neutral position. I'm going to put the patient's thumb into extension, and I'm going to provide pressure in the direction of flexion at the proximal phalanx of the thumb joint, of the thumb. I'm going to push down towards the ground, towards flexion. Don't let me move you. Stabilizing at the wrist. The thumb is going to be put into flexion, and pressure is going to be given against the proximal phalanx of the thumb towards extension. So I'm going to tell the patient, don't let me move you. Good.
Ligament, I'm going to stress that ligament by applying force. First, I'll just try to move. I'll see how much movement is there. Is there an excessive amount of movement to where I'm concerned that the ligament has ruptured? And in literature, it can vary from about 30 to 45 degrees sometimes of being able to get, depending on what you read, when you start to be able to abduct at the MCP joint. So I'm stabilizing the first metacarpal with my hand on the proximal phalanx about mid-shaft. I'm being able to apply the pressure radially to be able to determine how much joint play is there at the ulnar aspect of that MCP joint.
So are you applying pressure here with this hand?
I'm stabilizing with the hand that's on the metacarpal and applying pressure on the proximal phalanx. Now, sometimes if you're not experiencing a lot of excessive joint play because maybe the ligament has not completely ruptured, but there is possibly some micro tears within it, I will also oftentimes test it where I have the patients keep their thumb in extension, so keep your thumb there, and don't let me push your thumb out to the side, and I'll apply pressure radially.
So it's going to be this L sign, and I'm going to try to reverse the motion of the lumbricals and neuralgia and take these into MCP joint extension and IP flexion. I'll stabilize on the hand, and she's pretty strong, so that'd be a grade 5. If those were weak, I would be able to break that motion. If she couldn't go into full MCP flexion and IP extension, and she may have some.
That's good recoil. Okay? So I'm going to start off with your head, okay? Yes. I'm going to start off inspecting. I see nice, good curly hair. Let me look for any. No dandruff. Perfect. I'm going to palpate for some masses. Experiencing any pain?
No, ma'am.
Perfect. I do not feel no masses, no indentations, anything, okay? So now I move down. So I'm going to palpate on your face. No swelling. Perfect. Everything feels nice and good. Perfect, 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 perfect. All right, yeah. So can you scrunch up your eyebrows for me? Perfect. Can you smile nice and big for me? Perfect. Nice and symmetrical. Everything's good, okay? So now I'm going to go to your eyes. Can you look straight at me? Perfect. Your sclera is nice, bright, and white. I see no drainage. Nice symmetrical eyes. Perfect. Your eyelashes look nice. Your eyebrows look good. Everything's where it should be, okay? So now I'm going to have you, I'm going to take out my pen light and I'm going to have you look at the light. So your pupils were nice, equally, and reactive, okay? So now you're going to follow the light, okay? The pin. Perfect. Okay, everything looks good. Can you touch your nose with your finger? Perfect. Can you do the other hand? Perfect. Okay. Now I'm gonna look at your ears. Nice and symmetrical. I see no drainage, no excessive surround. Perfect. Okay. Now I'm gonna cover one ear and I'm gonna whisper. Okay. Can you hear me? Can you hear me? Perfect. Nice and equal. Everything's good. Nice and equal. Okay. So now I'm gonna go to your nose. So I'm gonna cover one ear. I'm gonna have you breathe in. Perfect. Nice and painting. Nice and painting. Okay. Perfect. Excuse me. And now I'm gonna have you smile nice and big for me. Perfect. I see your nice and teeth, nice straight teeth. Your gums look nice and equal. Can you stick out your tongue? Perfect. Can you move it side to side? Perfect. Up and down. Perfect. Can you swallow for me? Perfect. Nice. Trachea, no deviation. Nice middle trachea. I see no swelling, no nothing. Was that painful at all?
No, ma'am.
Perfect. Everything looks good here. So now I'm going to pass my finger through here. Can you feel that?
Yes.
Perfect. You can feel that. Perfect. Okay. So now I'm going to check your pulse. Nice, good, strong carotid pulse. Perfect. Now I'm going to have you move your neck forward, back, side to side, round. Perfect. Okay, now I'm going to have you shrug your shoulders. Perfect. Now I'm going to have you move your arms up and out and close to you and away from you. Perfect, 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 perfect. Okay, so now I'm gonna check your pulses first, and then I'm gonna listen to your lungs and your heart. Okay.
Yes. Now we'll go ahead and put the pin up and check the ear. Good. At this time, I would go ahead and assist his nose as well. I'll tell you to breathe in and breathe out. So he has no nasal septum deviation. I would go ahead and ask you to put your nose up and your head up. I'll look inside the nostrils for any discharge. Hairs grow evenly. No purulence, no redness, no irritation. Good. Good. Now I'm going to ask you to open your jaw as if you were chewing. Do you hear any popping? Any pain, discomfort, or do you hear any popping? Your thyroid. Starting with the inner chains, I would do the postparacrial thyroid gland and go down. Feeling for any chains that are present. And no chains are present. Good. Do you feel any swelling or inflammation?
No.
No? Any discomfort when you swallow?
No.
Okay. Now I'm going to go ahead and look at your throat. I'm going to see that your throat is in line, and I'm going to ask you to swallow. Swallow is intact. While I'm here, I'm also going to go ahead and palpate your carotid. I want you to turn your head. Good. Turn it again.
To start the diabetic foot exam, I would do a review of systems with the patient, talk to them about blood sugar control. When was your last foot exam?
A year ago.
Okay.
And my blood sugars are good.
Okay. I would look at the color of the foot, capillary refill, check the pulses. Look for the plantar flex metatarsal or any ulcers. Have you had ulcers before?
No.
I would look at the toenails, the sides, to make sure there are no signs of ingrown toenails or thickened toenails, which would be a fungal infection. Look for signs of athlete's foot in between the toes, which we treat with topical antifungals. And capillary. check the Achilles reflex, well actually, the telereflex, and you stop feeling it vibrate. Can you close your eyes, please? Just tell me if this is dull or sharp.
Dull. Sharp. Dull. Sharp. Dull. Sharp. Dull. Sharp.
You're going to be looking at the bottom of their feet, inspecting for any kind of calluses or sores, skin breakdown, cracked skin, anything that would be any kind of signs of an infection or a potential barrier for infection. And go ahead and feel the temperature of their feet while you're checking this. Whatever you do to one foot, though, you want to make sure that you're doing to the other. So we're going to check this one for anything, any kind of calluses. And again, this is so we can early detection of any kind of foot ulcers or wounds or anything. In diabetic patients, it's really hard for them to heal from ulcers, especially on their feet. Another thing we're going to look at is their toenails. You're going to look for thickening of the toenail, which is a sign of a foot fungus. The next thing that you're going to look at is around their actual toe bed, the toenail bed, to look for any kind of ingrown toenail. While you're doing this is a good time to go over with your patient about inspecting their foot themselves every day. They need to be looking at their feet daily. A lot of patients don't realize that the sensation in their feet have left. They don't realize when they've stepped on, and this is just due to the poor circulation and blockage of the arteries and veins leading to their foot. The next place you're going to is on the anterior side of the foot. It's right behind the ankle bone and right before the Achilles tendon. It's in a little groove, and you can just roll your finger over and in that little groove right there. Make sure though that you're not pushing too hard, because you'll occlude the pulse yourself. It won't be anything to do with the patient. This can be difficult.
Just going to pull the eyelid down. Have a look. Brilliant. Could you open your mouth for me? Now stick your tongue to the roof of your mouth. Brilliant. Again, uncomfortable, let me know. So take a deep breath in and out. And again. Again, I'm going to tap on your back.
That would happen. They have otter boxes. Oh yeah. Actually, I got this Google Earth. I have to talk to it.
Turn your hand up.
And we actually used it the other night, and we learned about the ruby in the sky and the diamond in the sky that are part of the Orion constellation. Orion's belt actually has one of the stars, which is two stars, that go around each other every 5.73 days. We still have to drive back and drive back. Well, you are using an abundance of useful rubies in the sky and Betelgeuse. And exactly the 600 river, like, yeah.
Put your hands to your side.
Dropping it off at a bed frame. Yeah. And then diamond in the sky is 840 light years away. And that was called, like, RITL. You know what? I love your jealousy right now.
Okay, push up to my hand. Don't let me bring it down. There we go. Okay, and then now I'm going to do your brachioradialis. So push up into my hand. Don't let me bring it down. Go. Okay. Okay. And then I'm going to do the same on this side. Here, keep your arm like this, and don't let me bring your arm down.
Okay, relax for me. Okay, now I'm going to do 2 on your lower extremity. Bring up here a little bit. Okay, just relax for me here. There we go. Okay, I'm also going to do your Achilles tendon reflex also.